Good evening, everybody. I'm Dr. Rick Lehman in St. Louis, Missouri, and this is 11/10/2020 in your corner with CORA. And tonight we're going to be talking about OCD, osteochondral injuries, and we're going to define osteochondral injuries here in a minute. But we've got basically an esteemed crew, and I'm going to have them introduce themselves, giving us a hand in discussing this topic. Dr. Voglino, please introduce yourself.
Hi, this is Jim Voglino. I'm an orthopedic surgeon practicing in Miami, Florida. Good evening.
And Mr. Fenton, James Fenton, you're up.
Good evening, gentlemen. My name is James Fenton. I'm a senior clinic manager and physical therapist down in Miami, Florida as well.
And thank you guys for joining us. This is a very important topic and a common topic for sports medicine doctors and orthopedic surgeons in general. And as we get started, before we jump into it deep, Dr. Voglino, please differentiate osteochondral defects and classic OCD or osteochondral or osteochondritis dissecans in terms of the anatomy and what exactly we're talking about.
Basically, what we're referring to is a spectrum of conditions that deal with the surface cartilage in the knee joint. And this is separate from the meniscus. The surface cartilage is normally the smooth, white, shiny area. And injuries and conditions where there's unstable defects in the cartilage, the classic osteochondritis dissecans is something that's mostly affects 10 to 20-year-olds, mostly related to sports, some spontaneous, but it's much rarer than the much more common osteochondral defects and lesions that, there may exist in 5 to 10% of the population that's over 40 or 50 years old that's been active. So they're two different conditions. In the juvenile population, it's relatively rare, but it's major when it presents itself. I think it's like about 1 in 10,000 people is the incidence in the 10 to 20-year-olds. So there's a spectrum of conditions that may or may not be related.
And when you talk about osteochondral defects or osteochondritis dissecans, what joints are we talking about? Which are the most common joints that you would see or any orthopedic surgeon would see? And how you said 1 in 10,000, and that's actually about right. What other joints do you see them in besides the knee, and where do you see them in the knee?
Well, it's most common in the knee. I mean, it could be probably found in any weight-bearing joint. They're seen in the elbow. They're seen in the ankle joint. Probably rarer, but I've seen them in the shoulder. I'm sure they could occur in the hip, but they're probably much rarer. I haven't seen them directly in the hip as much. But basically, all the joints where we do a lot of arthroscopy, we found them.
That's excellent. Thank you. And what's the etiology? Why do people get these lesions? Why does a 16-year-old come in with a OCD lesion that's broken off and has a locked knee? What's the underlying etiology?
Well, I don't think we 100% know the etiology. There's probably components of genetic and hereditary, but they're not really well defined. We think there may be some circulation contribution in the adolescent population. The pathoanatomy that occurs is that there's some type of circulation change or necrosis or death of the bone cells that support the cartilage underneath the cartilage. And then there actually is a kind of microfracture that could be from either a single traumatic event or it could be from a repetitive microtrauma. And it has some potential to heal. And some process like that may occur in a less potential for healing fashion in people that are skeletally mature or adults.
Thank you. So James, go ahead and give us a history. Patient comes in to the clinic. What's the normal history, or what's a common history that the athlete or the patient's going to give you when they present with an OCD lesion?
Common clinical presentation for a juvenile might be someone who's an athlete, spends a lot of time doing high impact activities, obviously from the training in and of itself that goes into this and the conditioning that goes into these types of sports. They're going to start complaining of pain. The subtle onset is something that we might typically see. just a gradual progression of their pain and their limiting symptoms to a point where often the patient is not able to return to their sport.
And in terms of complaints, is it just pain, or do they have mechanical complaints, or kind of give me the spectrum of complaints an athlete may give you when they come in and have subsequently been diagnosed as an OCD, let's say a lesion in the knee?
Yeah, so the pain is obviously going to be a big one. I think it becomes much more profound once they start realizing that they can't participate in their sport, whatever sport that may be. Mechanically, they're going to complain of a locking pain, right, or a locking sensation where they can't really use their knee as freely as they'd like to, and that might be one of the first things that kind of sets them off as well.
Thank you. And Dr. Voglino, go ahead and talk about your physical exam. Patient comes in, knee swollen, maybe they have some mechanical symptoms. Describe a standard physical exam, and describe the exam both for the knee, and then let's switch over to the elbow, and let's describe the exam in the elbow, please.
Well, with the knee, I mean, first observing, commonly they present with an antalgic gait or limp, decreased range of motion, mechanical signs on exam. There may or may not be joint tenderness. We referred to before, the classic juvenile lesion in the knee is actually in the posterolateral aspect of the medial condyle, which may be an area that may be difficult to directly palpate, but on physical exam, there is a test, it's called the Wilson test, that can be positive. And it's believed this physical exam test may relate to where the lesion is. Some people think there's impingement of the tibial spine where the ACL ligament attaches to the tibia, and that this may impact on the femur. So the exam involves with the patient seated or the knee flexed 90 degrees and applying some internal rotation to the ankle or foot region across the knee, and then extending the knee at a certain point, maybe 30 degrees short of full extension. It may cause that type of impingement symptoms. Other things that I look for on the exam may include contributory factors such as the overall alignment of the limb, ligamentous stability. Sometimes these are also associated with traumatic sports events, and there's other pathology associated with it. So we're looking for that as well. On the elbow, I would look for similar things, tenderness over the capitellum. I think that's one of the areas where it may be more common in the elbow. Besides the physical exam, there might be a loss of motion or swelling, compression across the capitellum, maybe with pronation, supination, may trigger those symptoms. I've seen that in gymnasts that have developed that.
It's excellent. Go ahead.
No, it's probably partly related to factors we don't fully understand, but then the repetitive micro and macro trauma of what they do as gymnasts, catapulting on their arms and balance beams and so forth.
No, that's exactly right. And mechanically, it's a problem, as you said, with their extension, swelling, and they have difficulty weight bearing, which gymnasts functionally do quite often. So go ahead and discuss your workup. Patient comes in, you suspect that they have an OCD, you get x-rays. What do you do next?
Yeah, well, typically we're looking for clues on the x-rays. Quite often they may be normal, but signs that may show instability if there's a loose body or sclerosis on a focal area of cartilage may be a bad sign, or if there's a loosened area with sclerosis. Those are things that may suggest that there's something unstable or a more long-standing lesion, the location of where findings are in x-ray. And also certain x-ray views can help us measure factors that may put more pressure on certain cartilage areas, such as the alignment, with standing radiographs or limb alignment radiographs. Particularly if a lesion is found, that becomes more important because the treatment may be affected by what other factors exist that may be causing force on that area of cartilage. The MRI is critical to working up these lesions. Most of them if they're unstable, are going to be seen on an MRI. But there are many cases, especially in the adult population, which I see, a much higher volume of, where the MRIs are not 100%. We know they range from, 80 to 90% plus for cartilage injury, but I think that it's higher for meniscus. Quite often we'll see incidental findings on the surface cartilage that we could not see on the MRIs that are presented to us. But the MRI is very important. The MRI also shows the other areas we're concerned about, such as the ligaments, the meniscal cartilage. Big meniscal tears may be a factor in why the surface cartilage is getting more stress in a certain area as well, including meniscal root tears. So primarily X-rays and MRI. There's also a role for a musculoskeletal ultrasound. I use that sometimes to assess the degree of swelling. We can see the surface of the joints pretty well. Sometimes we've detected loose bodies or the amount of instability in a joint or on a lesion with dynamic musculoskeletal ultrasound in the office. But it's not as sensitive diagnostically as MRI.
And kind of discuss, we're going to talk about classifications here in a second, kind of discuss the MRI findings, fluid between the OCD lesion and the base, kind of discuss what you're looking for on the MRI, specifically as it relates to the lesion.
Yeah, well, we're looking for changes, edema in the subchondral bone, areas of fluid collection, even more so than edema, would be more significant for a possible unstable lesion. Seeing cystic changes, particularly if there's a volume of cystic changes in the bone or in the subchondral area. If they're greater than 5 millimeters, it's been suggested that that's a more unstable presentation for a cartilage lesion. We're looking for displacement on the cartilage. We can see also on the surface if the joint fluid is filling in a defect on the surface, see asymmetry of the surface, and it can be measured on MRI when you can see it. So the size and location is also important. Thank
you. So do you have a classification you use in your practice? Hardy classification, any classification you use to, in your mind, grade these lesions, which may direct treatment?
Yeah, there's variations of it. The outer bridge classification is the one I typically refer to, or a variation of it, where 0 is normal, but the basic cartilage injuries range from 1 to 4, and the first 2 are more superficial. The 1 is softening. Grade 2 and 3 involves partial thickness cartilage lesions. The grade 2 would be smaller, maybe less than 1.5 centimeters. Grade 3 would be bigger, and with fissures, and fissures going down to bone would probably be grade 3. And then where there's exposed bone or a bigger lesion with exposed bone, that would be grade 4. And these are all on a spectrum where more diffuse changes would be called arthritis. And we're trying to hopefully prevent that or postpone that in these patients, or prevent it.
So James, Dr. Voglino sees a patient. He's going to treat the patient conservatively. They have a swollen knee, having pain, difficulty playing sports. He sends them over for therapy. Kind of give us your evaluation and your treatment protocol to treat that athlete.
Yeah, sure. So certainly we're taking a detailed history, trying to get as much information from the patient. Their subjective report is very important to us in the clinic, because that's ultimately where we're going to get our goals from, right? So we're trying to assess what their function is and where those functional deficits are, so we can really work on improving that aspect of their life. As far as the objective measures we're taking, certainly range of motion and strength is probably going to be the biggest part of this physical exam. If any special tests are indicated, we'll perform those in the clinic. And just assessing their gait pattern, their limb alignment, like Dr. Voglino had mentioned, obviously very grossly in the clinic. We're going to assess that, also their gait and their balance. If they're maybe an elderly person that has a higher risk of falls, that's going to be something that we want to assess as well.
Thank you.
Can I add to that? Can I add a comment to that?
Please.
Sure.
So in regards to the therapy, this is where whether it's a non-operative treatment or a rehab from surgery, the communication especially in these type of lesions, is very important between the therapist and the physician, because the details of a certain lesion based on the location, the size, there could be a wide range of, one protocol doesn't fit all. A patellofemoral lesion, for example, you may allow a person to weight bear on, but you don't want a lot of patellofemoral force. So, the therapist hopefully is going to be on board with the physician in a plan of perhaps limiting, flexion weight bearing exercise that'll increase patellofemoral force in that patient. Someone else who has a direct weight bearing large lesion, potentially unstable, there may be a period where no weight bearing is very important, and maybe some protected exercises can be appropriate. So there's there's many in between. There's some small lesions where it might perform a small microfracture and you may allow weight bearing, but you don't want any excess force like running or impact activity for a period of time. And a bigger lesion, it might be twice as long a period of time. So it's not an exact science, but the communication is key.
So Dr. Voglino, would you call James up and say, we're going to allow weight bearing in a straight brace, but we're not going to allow loading of the knee, let's say in a patellofemoral lesion, for a period of time? Or how do you transmit that communication, and how do you two guys, how do you communicate with each other?
Well, in my practice, what I do is I try to put the pertinent details, and this is one thing the electronic health record has actually helped with, besides causing me to become a better typist. I try to put the pertinent details, which we can easily copy and paste now, to a script that everybody can read. So if those details are there, hopefully they get transmitted to the therapist, and that the patient has a printed copy as well. We fax them to the therapist. And then, of course, on patients that we communicate verbally as well. But it starts with, something that hopefully I'm making a note of in a place in the note, in the plan, that my staff helps me make sure that is on the script. And certain lesions, there could be a protocol, but it's a little bit individualized because many of these patients have other things associated, and it's not always one size fits all.
And James, I'll ask you the same question. How do you communicate with Dr. Voglino? Do you call him, or do you go on the EMR and make corrections, or text him or Snapchat him? How do you guys communicate?
No Snapchat, no Snapchat.
Okay.
But we're certainly looking at the prescription and the referral from the physician to see if there's any special indication or weight bearing status or contraindications that the physician does not want the patient to do. And we'll obviously adhere to those pretty strictly. The EMR, like Dr. Voglino had mentioned, is a huge help because everything is there, everything is concise, you know exactly where to find it. Oftentimes we do get the visit note in addition to the referral, in addition to the prescription. And that gives us a good opportunity to kind of see what was discussed and what was performed in that visit. If for whatever reason there were some sort of misunderstanding or something wasn't quite clear, we make every effort to call the physician's office and clear that up before doing anything with the patient that may be a contraindication.
I think this is a good conversation in general, not just OCD, but talking about how open communication between the physical therapist and the surgeon really betters medical care. And I think a lot of times the physical therapist is somewhat reticent to call or interrupt the doctor. And I would say in most practices, the doctor would welcome some communication so that the patient's care doesn't suffer, or the physical therapist is somewhat conservative in their treatment when maybe they don't need to be. So I think this is a very helpful conversation discussing communication, which is obviously very important. Dr. Voglino, so you kind of made a little bit of a differentiation between a 10 and 20-year-old and older people. So someone has a standard OCD, vascular loss, cartilage surface breakdown. How do you treat that adolescent with open physis, or do you make that differentiation?
Yeah, I definitely more hopeful in an adolescent if it's not a very unstable lesion that there may be natural healing. So I tend to be more conservative unless I have signs of non-clinical progress, non-improvement with conservative treatment over a period which can range from weeks to 1 to 3 months. If there's something that appears to be displaced or unstable, the best thing is probably to fix it. And nothing as good as Mother Nature if you can preserve your own and have it heal well. And those juveniles have the best healing potential as well. But many of them may do well, depending on how they present, with conservative care, and there's a high healing rate. So that's more conservative at first, considering the communication with the therapist, activity modification, potential holding them back from their impact activity, sometimes non-weight bearing for a period of time that can range. Sometimes it could just be 4 to 6 weeks, sometimes less, sometimes more. The mature patient, it's a different animal. I don't give them quite as much time with conservative care because I know there's less healing potential, but we don't have 100% cure either for those patients. So it's a challenge.
Thank you. And so along those lines, patient comes in, maybe they're older, maybe they fail conservative treatment in their adolescence. What's your next step? And kind of discuss your surgical algorithm in terms of treating these patients surgically.
Well, I mean, whether it's a juvenile or an adult, if it's a relatively acute or traumatic presentation, if there's something that seems unstable and it's not stabilizing itself quickly clinically, then I usually would plan an arthroscopic procedure where it's the gold standard of assessing the lesion arthroscopically and being prepared for several intraoperative options. In a younger patient, and young can vary, but certainly in an adolescent and someone maybe in the 20 to 40-year-old age group, more ideally, the younger the better, perhaps. If there's something that can't be fixed directly, I like the idea of an Oates type procedure or mosaic-plasty. That's taking a transplant of autologous cartilage from a non-weight bearing surface and with bone and cartilage, bone at the base, and placing it into the defect. And there's a good success, high healing rate of that, and a good longevity. If it's someone who's more mature, there's probably risks to taking the cartilage, if they have some wear from another area, and typically the lesions tend to be of a size and nature that I might lean more towards. If it's a smaller lesion, maybe less than a centimeter or two, under 15 millimeters would be more ideal. Maybe considering a chondroplasty or a microfracture, which is arthroscopically, shaving the edges so there's no loose bodies, cleaning up the defect arthroscopically, and perhaps doing something marrow stimulation or microfracture to try and get a scar cartilage or fibrocartilage in the defect. And if it's a bigger lesion with good cartilage in other areas of knee, then there's consideration of other procedures which are more involved and usually staged that often we can't anticipate at the time of going in on a first procedure. And we can talk more about those. And those include either cartilage cell transplants or osteochondral allografts, which is from a cadaver shape matched cartilage with bone to fill in a larger defect. These are all trying to avoid replacing part of a knee joint that's damaged.
That's excellent. And so in an open physis, is your goal more to try to put the fragment back, or do you lean more towards a MACI or a graft? So now we're talking about the adolescent, maybe 12, 13 years old that has open growth plates. What's your go-to procedure there?
Well, if the lesion is not too large, I don't see a lot of those. I'm not a pediatric orthopedist. So if the lesion was not too large, I would probably be going to something like an Oates and be prepared to do it at an index procedure. If it turned, or repairing it. To repair a lesion, there's got to be enough of a base to hold some type of fixation. My go-to with repair would be either chondral darts, which is, or some type of headless cannulated screw system where I would plan on taking the screws out after there's sufficient healing, which might be in 3 to 6 months or something like that. There's also, if it's a lesion that's not totally unstable, there's a role, it's not as common in my hands, but there's a role for trying to stimulate it by just drilling alone, either across the cartilage and sometimes with guides, almost like an ACL guide from the back of the knee to, and with fluoroscopy to try and stimulate circulation into the defect from beneath it. But that's not something that I have a lot of personal experience with. A bigger lesion in a young person is a problem. That's where the cartilage chondrogenesis type procedures, where they're growing cartilage cells in a lab, like the ACI or the Macy procedure that, if we want to talk about those, we can. Those have a definite role. And there are, a number of younger patients. That's where you can actually create high quality, hyaline-like, more natural-like cartilage by, in a staged procedure, taking some cartilage cells, and then the lab can grow them and have them replicate. And it can be either with or without a scaffold. The Macy procedure is when there's a collagen scaffold that they can grow these cells on, and it's an FDA approved procedure. And then with a second procedure, this can be implanted and shaped to the exact shape of the defect, and either placed with a fiber and glue, or sometimes with fixation devices such as sutures and small suture anchors, and then there's a period of healing and remodeling. But these are big stage procedures with a long rehab and high expense as well. So we have the challenges in those patients. It's worth the challenge in the younger patients that need it. Those patients, we have to go through special authorization processes. We're talking about procedures that are 5 to 10 times or more the cost of the other procedures, but they do have much better longevity, and holding up over 5 to 10 years, or hopefully even longer.
Thank you.